كده في صوت؟ كده في صوت في الزوم؟ اخبار الزوم ايه؟ How is the sound؟ معقول ما فيش صوت في الزوم؟ ليه مش هيبقى فيه صوت؟ اوديو اهو. اهو المفروض ان يبقى فيه صوت. اخبار الصوت ايه؟ اوكي تمام. ها قول. مساء الخير يا جماعه، ازيكم؟ اخباركم ايه؟ كله تمام؟ كله تمام. طيب. آه محتاجه اقول كده شويه حاجات زي ما بيقولوا. آه housekeeping issues. كان بودي جدا ان انا to stop to explain every detail وان انا امشي بنفس البيس اللي كنت ماشيه بيه. any non-Arabic speakers. any non-Arabic speakers. I would have liked so much to walk يعني to proceed in the same pace and explain all details. Maybe we'll have a chance after the end of module exam. Our target is the end of module exam. That's why I'm going to be quick. I'm going to stop at some concepts, okay, and perhaps show some slides. But I'm going to be very quick and try to be to the point. Not only this, after tomorrow's lecture, I'm going to finalize your orientation, which is going to be in the form of ILOs. Okay? You are going to see all the ILOs of 208. And I'm going to highlight the ILOs. Most of them will be highlighted. Most of them will be highlighted. But at least if you go by the ILOs one by one, you know what you're studying. Another thing is, هتلاقي ILOs مكتوبة mention, define, describe, explain. You don't need to care about this so much, except in the level of detail you need to understand with. In describe, you need to understand the detail. Explain, you need to understand the detail. Mention, enumerate, just enumerate the points. كده, this is going to be an MCQ exam. So I need to worry about the ILOs, not you. The way I put the question needs to satisfy this ILO. However, in the end of year exam, I'm going to tell you what sort of questions to memorize. I'll tell you, you'll have perhaps 3 types of questions. There's always explain the mechanism of action. طيب ده معناه ان انا if you describe the mechanism of action, اي دواء, any drug that has a detailed mechanism of action that I'm going to mention them specifically as I go along. I don't want you to memorize it for this exam. Why? I know how much load you have. انا عارفه اللود اللي عليك. وما بنلغيش حاجه عشان النكته الشهيره بتاعه العيان اللي راح لك قمت قلت له ايه؟ ما كانتش علينا، كانت ملغيه. اوكي؟ So we don't do this. طب what do we do? I put the ILOs in front of me and I make sure that you study them for one of the 3 exams. يعني this exam you're going to have so many ILOs to study because this is an MCQ exam. It depends upon your understanding and your reading. This is your foundation. Next end of year exam, you will know which ILOs to memorize for writing. That's why I will not ask you to explain or to memorize detailed mechanisms of action. وهقولهم in specific which ones, not because they are cancelled. No, they are postponed for the next exam. Okay? Likewise, I will reserve some material for the practical. Perhaps you'll have some pages for your practical exam. because they are related to your practical. They will serve some explanations for your practical. In this way, I'm going to split up or divide your curriculum so you don't have so much load, and I insist that you study and read everything. Okay? طيب خلاص talked so much. يلا أبدأ Autacoids. طيب some people think that Autacoids is not an important chapter. It is very important. You know why? You know why? I didn't like it. Why? Because it's heterogeneous. It's from here and there. It's not a system. It's about local mediators. By the way, Autacoids means self-remedies. These are local mediators from here and there. Histamine, serotonin, peptides, prostaglandins. Okay? There is nothing to collect them all together. That's why myself as a student, I didn't like it. But why do you think it's important? Why? Huh? Looking at your schedule of lectures, there are 3 lectures on Autacoids. 3 lectures, بصرف النظر. So anything with 3 lectures, you are almost sure to have 5 questions in this topic. So if you have 3 lectures for Autacoids and migraine, you have 5 questions in this. This is the way it goes. We're going to divide it. If it's not important, I shouldn't give it a lecture. I shouldn't. Type. So how to go about this? First of all, you need to know, again, the highlighted text in yellow. Of course, you need to know just the classification or the groups of Autacoids that you have. I always want you to know الchapter ده بيتكلم عن ايه. As you can see, I don't highlight any background. But Autacoids have maybe 3 or 4 important topics that you need to focus on. Antihistamines, this is one. Endothelins, this is one. Prostaglandins, this is one. Of course, migraine. And I hope I have not forgotten anything. It will come. Okay? Yeah, this is good. Serotonin is important, but honestly speaking, يعني I will not really, the thing with serotonin is that everything, almost everything in serotonin has been mentioned elsewhere. يعني ondansetron, you're going to find it in the antiemetics. SSRIs, you are going to take it next year with the antidepressants. So not everything in serotonin. I'm going to focus about things that have not been mentioned or will not be mentioned elsewhere. So again, to make you focused. تمام? So his antihistaminics are very important. What do you know about the difference between first and second generation antihistaminics? Anyone tells me? So second generation antihistaminics, first generation, they basically pass the blood-brain barrier. And are they selective or non-selective? They're blocking H1, and some of them even block muscarinic M1 receptors, and they cross the blood-brain barrier. And if you block the H1 in the brain, you produce sedation. So these drugs produce drowsiness and sometimes anticholinergic manifestations. So we have the second group, or the second generation antihistaminics, which are not crossing the blood-brain barrier, they are not causing sedation, and they are more selective. So which do you think is better? Yes, I wanted to hear this. Each one of them has its application. I have common cold. I want to take something antihistaminic that will reduce any allergic manifestations, that will antagonize histamine, that will reduce vasodilation, and I want to go to work. So I take the second generation antihistaminics. On the same day, I return from work and I want to have some night sleep. So I take an antihistaminics from the first generation. Next year, you will take hypnotics. One of the hypnotic classes are antihistaminics. First or second? first, you can't have the second. Here the second are no good. And why are they still very important? Hypnotics, the first generation antihistaminics, because you will know that next year they are non-addictive. You can take them over the counter. A medication for sleep that's not creating an addict. Okay, so it's not that one of them is better, it's that each one with its properties has its own application. So each one, they are distributed, as you can see, skin and the CNS. Okay, these are the receptors. These are just the receptors. Okay, so the receptors and actions are these for the background. I'm not going to put direct questions about the H1 and the H2 receptors. Yet you need to know them. Okay. However, I am very much interested at the comparison between first and second generation antihistaminics, and I have highlighted the names that I need you to memorize. Not all the names, but names are here. Some names are very important. Because as a doctor, you need, when you look into a drug with a trade name, to know what it is, especially if it's very commonly used. I cannot expect you to memorize all names, but I am highlighting the names that I'm interested in. So these cross the blood-brain barrier, more lipid-soluble, block some autonomic receptors, and because they're lipid-soluble, they have a short duration. However, the second generation are a longer duration drugs, not blocking autonomic receptors, and they do not cause sedation. So the effects related to H1 block, the relief of itching, capillary permeability, and decreased bronchoconstriction. Okay, and of course, you know from the kinetics. Other effects with the first generation, they produce sedation, sometimes atropine-like action, anti-emetic action in motion sickness. You're going to take that in the GIT module. Very important topic, the anti-emetics. Some have alpha blocking action, and some even block the 5-HT receptors. So this table is a very important table. Of course, the therapeutic indications, as you see, are still very important. The common ones, of course, in allergic conditions and in motion sickness. And why is that? Again, you're going to hear that next module with the GIT, with the anti-emetics, vomiting due to motion sickness. The inner ear, it has two types of receptors, H1 and M1 receptors. So these two blockers are good in motion sickness. That's why you heard about what? Hyoscine. So you have two drugs for motion sickness. You have hyoscine because it blocks the M1, and you have H1 blockers. But which group? The first generation. So you see, it's not just that the second generation are better. It's just different indications and different uses. Any questions here? Of course, adverse effects, they will follow the same non-selectivity pattern. But a problem with the second generation is that are metabolized. They are metabolized by cytochrome P450. And the problem is that some of them are prolonging the QTR interval. And so any drugs that inhibit the cytochrome P450 can increase their level and can result in something called Crozat de Pointes. This is a very important interaction. You know why it's important? Because it is a life-threatening interaction. And it's very easy for anyone to take an antihistaminic for common cold, even over-the-counter products, and then take an inhibitor of cytochrome P450. And you are confronted with arrhythmia, and people don't know what the arrhythmia is coming from. Okay, where is it coming from? طيب, drug interactions, okay, طبعا دول they can potentiate sedatives, and these ones have the interaction with cytochrome. As you can see, serotonin, I've just highlighted in green to tell you this is for reading, this is for understanding. For the serotonin antagonists, okay, sumatriptan and zolmitriptan, they have been mentioned in migraine. Buspirone, you're going to hear about it next year in the CNS. Maybe, if I want you to memorize something, even this etopride and cisapride, they will be mentioned in the GIT. يبقى gentleman agreement كده serotonin تفرق دمه بين القبائل أو الشباب زي ما أنت قلت. طيب. Yes. Okay. طيب. Things that will not be mentioned elsewhere for serotonin. Okay. Cyproheptadine, ketanserin. Okay. These are the two drugs that will not be mentioned elsewhere. Okay. Otherwise, I will ask about serotonin in other places, not here. Okay. Again, ergot alkaloids. Now, this is important. This is a bit redundant because the talk about ergot alkaloids is repeated in migraine. However, here we talk about hyperprolactinemia and we talk about postpartum hemorrhage. Now, ergot alkaloids are of alkaloid origin, derived from, produced by fungi. And by the way, in the regular lectures, I show photos of contaminated grains with the fungus, sometimes resulting in gangrene, because some of them are powerful vasoconstrictors. Yes, okay, so sometimes, some have alpha blocking action and some have vasopressor action. So they can produce gangrene. I'm interested here in the indications. Migraine, it's going to be repeated in the migraine. Hyperprolactinemia is very important to know that some derivatives of ergot alkaloids include bromocriptine and cabergoline. And these are agonists or antagonists at dopaminergic receptors. Yeah, agonist or antagonist? Agonist. حلو. طيب, remember, dopamine equals what? In order not to become confused, because this area about dopamine is confusing and it's going to become even more confusing next year with Parkinsonism and schizophrenia. كله بقى هتلاقي حاجات عكس بعضها. Remember one thing, dopamine equals prolactin release inhibiting hormone. Remember this. Hold on to it. Remember it. You are good. So if you are asked about anything that treats hyperprolactinemia, this is a dopaminergic agonist. And if you want to inhibit hyperprolactinemia, you look for something that's agonist to dopamine. تمام؟ So this is an important piece of information. Now, تمام, it's sometimes bromocriptine is even used in pituitary tumors because it's going to inhibit the pituitary as well. معناه ان انت you need just to read it because this information sets the basis for information that you need to memorize. So you will not be able to understand the information colored in yellow unless you understand what's colored in green. But I will not get direct questions in the green areas. Not direct questions in the green areas. Okay? Right. Again, because of the vasopressor action, a product which is called ergometrin, and again, this is very easy to memorize because metrin comes from the myometrium. So ergometrin comes from the myometrium. It pertains to the uterus. This is used to given for the time of delivery of the placenta to decrease the postpartum hemorrhage. Now, I want to explain this because this is important because I worked in OB-GYN sometime in some part of my life. If you want to augment labor, you use oxytocin. Why? Because oxytocin is going to increase the normal rhythmic contractions of the uterus. Okay? You cannot use ergometrin because ergometrin is going to produce tonic uterine contraction. So if you want to control postpartum hemorrhage, you can still use oxytocin if the bleeding is not severe. However, if the bleeding is severe or you expect severe bleeding, you can give ergometrin. However, you give it after delivery of the placenta. Why? Otherwise, the uterus is going to tonically contract, retaining the placenta itself, and placenta will not be delivered. So now you know the difference between them, okay? So toxicity and contraindications, the GIT disturbances, vasospasm, gangrene, especially in cases where there is contamination of grains, as I told you, in which case you can remedy it with nitroprusside or nitroglycerin because these are direct vasodilators, okay? Now, with vasoactive peptides, you just know that some peptides are vasoconstrictors, some peptides are vasodilators. This is just the classification. And again, with angiotensins, you just need to know that there exists angiotensins called angiotensin 1, 2, 3, and all of them are peptides. So it's important to know that these are peptides. Now, regarding the renin-angiotensin system, as you can see, I've colored it all in green because it's all going to come in the treatment of hypertension. Do you understand this? But the direct questions are going to be asked with the specific inhibitors of the renin-angiotensin system. Now, this one I need you to know, this is a list of renin-angiotensin system inhibitors. دي تجميع, you need to know it. What will inhibit the renin-angiotensin system? A beta blocker or an alpha-2 agonist that's going to decrease renin from the start, or a blocker of renin, or ACE inhibitor, or angiotensin receptor blocker. So this is the list of 4 inhibitors of renin-angiotensin system. Just a second. ده ايه ده؟ انا جايه بس في حاجه مهمه عندي. لا ازاي؟ كتر الف خير. طيب okay, again, any of these are going to do what in potassium? potassium, plasma potassium. اي حاجه في دول هتعمل ايه في البوتاسيوم واحنا مغمضين؟ هايبركاليميا. انا بقول الكلام ده ليه؟ sometimes you get confused. لازم تلاقي نفسك ثوابت. You should find things to cling to so that you're not confused. هو انت دلوقتي لما بتقول الرنين بيعمل كذا، انت قصدك علشان هو انزيم؟ عديه. انا مش هسأل عنه اصلا. ليه؟ Aliskiren is a drug that's been long in the market and we don't hear about it a lot in the guidelines. It's not there so much. So for me, it's important just to know it on the list of inhibitors of renin-angiotensin system. I will not ask about details with Aliskiren. However, okay, this is the only mention of icatibant, which is a decapeptide. This is a selective antagonist of bradykinin receptors, and it's in the treatment of rare diseases, which are the attacks of hereditary angioedema. This is very specific, so this just for you to know that there is an application for bradykinin. However, this application is limited to a hereditary disease, which is not very common. Okay, now, endothelins are important. This one sentence is important. Why? Because we have a very nasty disease that's called pulmonary hypertension. And what is pulmonary hypertension? It is hypertension in the pulmonary vasculature. مش احنا عندنا systemic circulation و pulmonary circulation؟ طيب, sometimes there is hypertension in the pulmonary circulation. طيب, why does this happen? It either happens secondary to something or it's primary pulmonary hypertension. What's the problem with this? This is a disease with very bad prognosis and very limited efficacy of any treatments. Okay, they have very limited efficacy. That's why you need to know there are options, and they are using something like bosentan, which is an endothelin receptor blocker. That's why I colored this green, because you need to know that the endothelins, they produce vasoconstriction, and this endothelin mediators are important mediators in primary pulmonary hypertension. That's why when you block them, this is a good option for patients with pulmonary hypertension. So this single sentence is an important sentence. Yes. Zoom? How? I have two drugs here. I have bosentan and ambrisentan. Okay, I just need to know that they are drugs for pulmonary hypertension. As you can see, eicosanoids, this is a background. This is going to be repeated and repeated and repeated so many times. So perhaps we'll ask about it later on in the CNS. However, effects of prostaglandins, I have colored them yellow, even though they are just effects, because they are very important basis for the application of prostaglandins, which is in fact a very important topic. So you need to memorize the uses or therapeutic uses of prostaglandins. Prostaglandins are mediators in many areas of the body. Okay, so they can be used, dinoprostone for induction of labor because they stimulate the uterus. Alprostadil is used for the treatment of erectile dysfunction because it produces vasodilatation. So as you can see, this is prostaglandin E2, this is prostaglandin E1 analog, and misoprostol is E1 analog, but it is used for gastric protection. You're going to hear about it a lot in the next module. For the cardiovascular system, you have alprostadil, okay, and you have epiprostinol. This is epiprostinol is used again for the treatment of pulmonary hypertension. So this is another group of drugs. Prostaglandin I2 is another name for it is prostacyclin, which produces constriction or dilatation. Vasodilatation, that's why it has this indication. It's used for IV with IV infusion. Alprostadil is prostaglandin E1. Again, it's vasodilator. It maintains the patency of ductus arteriosus prior to surgical correction of congenital heart disease. I need to explain this. طيب دلوقتي sometimes although I don't have a photo for this, sometimes some babies are born with major congenital problems in the heart. Okay, these major congenital problems, it's going to shift the circulation in some odd way. You need to correct this. But the presence of the ductus arteriosus patent maintains the life of the baby until you perform the surgical operation. So as if you have something very wrong, congenital anomaly, but the circulation is running because the ductus is patent. Okay, so you need to keep this ductus patent until you perform the operation for the baby. So how do you keep the ductus patent? You give something that's a vasodilator. That's why alprostadil here is good. It's a vasodilator to maintain the ductus patency. Yes. And other anomalies, okay, I can't name them now. Usually I have photos for them. As I told you, we don't have all the time to explain the details, but just for you to know that we need to maintain the ductus patent to correct temporarily or to keep the baby alive until we correct the anomaly. طيب الانهبitors of eicosanoids دي تجميعة مهمة قوي. You can inhibit phospholipase E2 by glucocorticoids. By non-steroidals, you inhibit the cyclooxygenase pathway. The Zoxibin inhibits thromboxane synthesis, and the anti-leukotriene drugs, they inhibit the leukotriene pathways. دي بس just تجميعة. هي حلاوتها انها هي تجميعة، انها مجمعة كل حاجة بالنسبة لنا 1 2 3، بس كل حاجة هتتقال بديتيل في حتة تانية. نيجي بقى للمايجرين. انا I colored هنا بس ايه الكالسيتونين to know that there is a new drug that targets the calcitonin in the prophylaxis of migraine. طبعا انا I will not say details about, of course, the stages of migraine, how there is a vasoconstriction, and then vasoconstriction with the accumulation of metabolites result later on in vasodilatation, and here's where the headache happens. That's why you have two contradictory mechanisms. Drugs that are needed for prophylaxis, they have to prevent this vasoconstriction. But once the dilatation happens, you need to have a vasoconstrictor to end the acute attack. So this is in short, and I am sure you all know about it. So you need to know simply, okay, the drugs that are available for a treatment of acute attack and prophylaxis. Ergot alkaloids, one of the list. Okay, partial agonistic action on alpha-1 and serotonin leading to vasoconstriction. So these drugs are used for the acute attack. However, they might stimulate dopaminergic receptors, and dopamine leads to vomiting, vasospasm, okay. The action, they can have oxytocic action, they can cause bradycardia, they can cause nausea, vomiting, as I told you. These are adverse effects and contraindications. They are very important because some are very serious. Okay, so these are mostly expected. يعني with the adverse effects, sometimes you have things that are expected, explained from the mechanism of action, وساعات حاجات مش فاهمينها. دي كلها تقريبا مفهومة. Extremities علشان الvasospastic action, الhypertension والangina for the same thing, same reason, nausea and vomiting because of working at the dopaminergic receptors, and abortion because of action on the mymetrium. And the triptans, again, in treatment of acute attack, these act by stimulating serotonin receptors, okay? So they are going to constrict the blood vessels that are abnormally dilated. They can be used orally or subcutaneously, okay? And again, they can lead to chest pain and coronary vasospasm, and contraindicated in angina, hypertension, peripheral vascular disease. كل دي علشان الفازوسبازم. البريجنسي ممكن برضه يكونتراكت اليوترس. Not given with ergometrin. Why? Okay, added vasoconstriction cannot be given together. Type treatment regimens, okay, they can be used for a mild attack. Okay, for a mild attack you use paracetamol. The algorithm to use paracetamol, non-steroidals. This is a mild attack. لو معاها vomiting هنستعمل حاجة anti-emetic، هناخدهم بالتفصيل in the next module إن شاء الله on the GIT. For a severe attack you use ergot or you use triptan. Okay, as you can see, I'm not telling you to memorize what makes you use prophylactic medications for migraine. I will leave this for internal medicine to tell you about it. But why is it here? To tell you that there are criteria. There are criteria. يعني not any patient is going to receive prophylaxis. Okay. تمام. What is this? Between attacks, okay, you use, and this is the benefits of prophylactic treatments, and دي تجميعة prophylactic treatments. Okay, the mechanism mostly it's not understood, but you need to know the available medications for prophylactic treatment. This is a trial to explain the mechanism behind each class of drugs. Beta blockers, especially propranolol, they can stabilize blood vessels. Antidepressants, some of them have alpha blocking action. Also, they decrease neuronal excitability. Anticonvulsants, they might work at the trigeminal vascular thalamic pathway. Calcium channel blockers produce vasodilatation. And now there is a monoclonal antibody which blocks calcitonin gene related peptide release. This is a new drug, so you just need to know the available drugs for prophylaxis. تمام. Any question in Autacoids? Anything not clear? Anything not understood? Clear, بسيط. Okay. Anything? Huh. Propranolol. Propranolol. لإيه؟ يعني إيه heterogeneous؟ أنا أسألك إنها heterogeneous ولا لأ؟ لو جه سؤال في الأوتاكويدز، في الأغلب الأوتاكويدز فيها أسئلة MCQ، فهيبقى في definite fact أنت بتسأل عنه. طيب now بقى we move to diuretics. طيب كلام بقى مهم في الدايوريتكس جد بقى. طيب in the cardiovascular system we have how many chapters or how many lessons or topics? We have the diuretics, we have the angina, we have the hypertension, we have heart failure, and we have arrhythmia. طيب famous funny thing about diuretics in people who are not very close with the internal medicine and pharmacology. When we used to plan the curriculum, they wanted to put diuretics with the kidney, with the renal system. No, these are cardiovascular drugs. Okay, so basically speaking, we have 6 classes of diuretics, 3 of which are very important and you need to know them in details. And the other 3, you need to know their uses, mechanism of action and uses in short, because they are not there in much details. كده الdiuretics كلها مهمة. بس let me focus on some points. First of all, this is the classification. تمام. As you can see, regarding the names that you need to memorize hydrochlorothiazide, but again, I need you to know indapamide because it's been mentioned elsewhere. طيب. Everything in diuretics is almost important. Everything in diuretics is important. Everything. These are thiazide diuretics. For diuretics, I need you to know even the route of administration. Which ones are available orally only and which ones can be given IV. If route of administration is mentioned, please know the route of administration. Now, this part about the kinetics of thiazide diuretic tells us that they must be secreted in the proximal convoluted tubule to start acting at the distal convoluted tubule. تمام؟ طيب. What is the importance of this piece of information? ها؟ يعني ليه مهم أعرف? Why is it important to know إن أنا thiazide diuretics they will be secreted by the proximal convoluted tubule and then they will act from the luminal side in the distal convoluted tubule. Because you need to have renal function for thiazide diuretics to work. You need to have renal function for thiazide diuretics to work. So this is a very important application. This is number 1. So if you have poor renal function, how do quantify renal function? By what we call glomerular filtration rate. So if the glomerular filtration rate is below 30, thiazide diuretics will not even be secreted and they will not act, so you cannot use them. They might even be dangerous. What's another application? Now, what is this secreted? يعني ايه secreted? How many processes control renal function or excretion? 3, filtration, reabsorption, and secretion. What is this secretion? These are carriers that take the drugs hela bela and they kick them out. A carrier. How many carriers do you have? How many carriers? 1, 2, 5, 10. As many as we have from drugs. Drugs we have, how many? 2 carriers. 1 for acidic drugs, 1 for basic drugs. Which means that acidic drugs are going to compete on the same carrier. And basic drugs are going to compete on the same carrier. يبقى this is the site for what? Drug-drug interaction. So if we have something like probenecid, it will inhibit the diuretic effect because again thiazide diuretics will not be secreted. حاجة عايزاكم تاخدوا بالكم منها. ده ايه؟ ده ايه ده؟ This is the tubular cell. You have something called the luminal side and something called the basolateral side, the side of the blood and the side of the lumen. Thiazides act from which side? From the luminal, so they need to go into the lumen. That's why this is an important drug interaction. Okay, and they lead to uric acid. They lead to decreased uric acid excretion. So the kinetics here are very important. Why? Because each point has its application. تمام. طيب, we come to the pharmacodynamics. We talk about the diuretic effect. We continue that they work on the distal convoluted tubule, that they are going to inhibit the reabsorption of sodium and chloride in the distal convoluted tubule, leading to excretion of more sodium. Now, what happens if the kidneys excrete more sodium? What happens? هيحصل ايه؟ هيحصل دلوقتي ان anything before the collecting tubules, تمام? The collecting tubules are doing the fine adjustment. They are controlling how much percentage from the sodium reabsorption, the collecting tubules, the distal part of the nephron. What is the percentage? قد ايه؟ اولا اللوب بيكنترول قد ايه؟ طيب والديستال convoluted tubule دي بتكنترول قد ايه؟ 5 من 5 ل 10 تمام. والديستال 5 حاجه بالشكل ده. طيب ماشي، ده بيريفلكت على ايه؟ بيريفلكت على ايه؟ بيريفلكت على الباور of what? Of the diuretic. If the diuretic is acting at the site of the loop, it's going to be what? A powerful diuretic. If it's working on the distal convoluted tubule, it's going to be moderate efficacy. If it's going to work on the distal on the collecting, the distal part of the nephron, collecting tubule, it's going to be a weak diuretic. As a rule of thumb, whenever the sodium is excreted كتير كتير كتير, يجي collecting tubule يقول يا خبر ابيض, all this sodium I'm losing it. What am I going to do? I'm going to try to reabsorb sodium in exchange for what? Potassium and hydrogen. But will this be enough to correct the loss in sodium? No. رميت البوتاسيوم في اليورين وما عوضتش الصوديوم. Because أول حاجة, this is a low efficacy system. It's not very efficient. It's a fine adjustment system at the end. This is one thing. Next is, what is the concentration of sodium you have in plasma? أنت بتتكلم في قد إيه؟ 130 something, 140. What is the concentration of potassium? 3.5 ل 5. انت عايز تعوض لي ابو 838 بابو 5، يبقى هجيب ايه؟ هيحصل هايبوكاليميا وستيل هيبقى فيه هايبوناتريميا. يبقى احنا كده فهمنا الدنيا جت ازاي. تمام؟ حلو قوي. So there is hypovolemia, sodium and chloride and water. Hyponatremia لان مهما اذا عملت الcollecting tubule it will not be able to correct the loss in sodium. And hypochloremia, الكلورايد اللي نازل مع الصوديوم. hypokalemia, hypomagnesemia and alkalosis. اوكي. hypomagnesemia خدها كده rule of thumb برضو, it is going to الهايبومagnesemia is going to follow the potassium. اوكي. دايما يعني اقول هايبوكاليميا هايبومagnesemia الى ان اشعار اخر. اوكي. طيب والكالوزس because you are losing chloride. اوكي. and you are losing hydrogen in exchange for sodium. يبقى كل ده explained ولا لا؟ explain. تيجوا بقى الهايبركالسيميا. بتحصل ليه الهايبركالسيميا؟ anybody knows؟ I'm trying to resist ان انا to say details, but sometimes I cannot resist. I have to explain this. Why does it happen? I have some selections for you here. I have this. This is comparing the mechanism with the thiazide and the loop. And this is telling us why thiazide diuretics are going to cause hypercalcemia and loop diuretics are going to cause hypocalcemia. First, we need to agree on something. Are thiazide and loop diuretics working on the same site or not? No. Are the cells different? Yes. Are the channels different? Yes. So let's see what happens with the distal convoluted tubule. With the distal convoluted tubule, there is going to be decrease in intracellular sodium because we are inhibiting the sodium uptake by distal convoluted tubule. Type. Can you see this? Okay. This is an exchange channel that lets sodium in the cell and calcium out of the cell. Again, I remind you, where is the luminal side and where is the basolateral side? This is the luminal side. It's yellow. This is urine. And this is the basolateral side. It's blue. It's the bloodstream. So we have many channels. The status now, we have inhibited this. We have inhibited this one. We inhibited it. صح كده؟ دي عملنا عليها ايه؟ كروس. صح؟ ماشي؟ طيب. صوديوم. حلو كده؟ طيب، اللي حصل الصوديوم انتراسيلولر قل ولا زاد؟ قل. طيب، ده يأكتيفيت انهي channel؟ انهي باثواي؟ انهي؟ يأكتيفيت ده. اللي فيه صوديوم كان بيحاول يعوض الصوديوم اللي كان، والكالسيوم رايح فين؟ جوه. انا ماشيه ناحيه اللومن ولا ناحيه البيزولاترال؟ بيزولاترال. اي دايجرام تشوفه في كتاب محترم توقف وحاول تفهم هذا الدايجرام. مفيش حاجه ولا لون محطوط without a reason. It's all sending messages. It's all by logic. تمام؟ طب تيجوا نقول اللوب بالمره بقى عشان نخلص. طب اللوب شغال على ايه؟ اللوب شغال على سيل تانية، خليه اخرى. الخليه دي اللي هي بتاعت ايه؟ اللي بتاعت السيك ascending part of loop of Henle، اللي وظيفتها ايه؟ It is creating this transporter، التريبل ترانسبورتر ده، الكو ترانسبورتر دوت. its function is to create very salty medulla. Very salty medulla. Because when there is salty medulla and interstitium, it's going to absorb water and a very big amount of water. Okay? طيب, I'm going to inhibit this. Okay? I will inhibit this. طيب, this one, what is it carrying to the inside? It's carrying sodium, chloride, and potassium. Here, potassium is a player. Because look at the potassium and concentrate on potassium. I have potassium going into the cell from urine. I have potassium going into the blood from the cell. And I have potassium going out of the cell. What is this potassium going out of the cell doing? It's creating positive potential to help the absorption of magnesium and calcium from between the cells. Can you see it? Can you see it? So, هضرب التريبل ترانسبورتر، يبقى أنا كده what happened to the potassium inside the cell? Increased ولا decreased؟ ركز على الترانسبورتر اللي أنا حرقته. ركز على الترانسبورتر اللي أنا وقفته. ركز على الأسهم داخلة وخارجة، ما تلخبطش نفسك. كده البوتاسيوم اللي داخل قل ولا زاد؟ قل. So potassium inside is going to decrease. So what is going to happen to this channel? Is going to decrease. The drive of potassium to go out and to create a positive potential for the calcium and magnesium to go in is going to stop. That's why I'm going here to have hypomagnesemia. So, and hypocalcemia. Hypocalcememia. So now you have seen with your own eyes without memorization why are thiazide diuretics causing hypercalcemia and loop diuretics causing hypocalcemia. دي الأسئلة. I get you a complex case needing a diuretic with hypocalcemia or hypercalcemia. You know what to choose. But this time, based on understanding. when I tell you thiazide diuretics in osteoporosis حلوة ولا وحشة؟ For a patient with osteoporosis, would thiazide be good drugs or bad drugs? Good drugs. If I tell you that you have calcium stones in urine, calcium stones in urine, thiazide diuretics هتبقى حلوة ولا وحشة؟ حلوة, because increasing calcium in the blood means decreasing calcium in the urine. Based on understanding. Always remember this. خلاص كده نرجع لمين؟ نرجع للكتاب بتاعنا. بطلي ديتيلز بطلي ديتيلز بطلي ديتيلز. اوكي ها. ممكن، بس يعني عارف ان انت لو انت قاعد بقى سبت الطب كله وهتكتب كتاب فلسفه. اوكي ماشي. طيب الميكانيزم they block the sodium calcium transporter, excess sodium chloride will reach distal convoluted tubule. نضحي بالبوتاسيوم والهيدروجين، ما عملناش حاجه، وصلنا لده كله. hypercalcemia enhance both passive calcium reabsorption and sodium calcium exchange. therapeutic uses. ايوه what are the therapeutic uses of diuretics؟ عايزه اهم ثلاثه therapeutic uses of diuretics. I want to hear the most important 3 indications of all diuretics. hypertension, edema, heart failure. hypertension, edema, heart failure. طيب are they true for thiazides? Yes. Are they true for loop? Yes. Are they true for potassium sparing diuretics? Yes. Oh my, where's the difference? The difference is here. I advise you to do this, please. معلش انا مش قادره اكبر قوي، بس هحكي لكم انا شايفه ايه. دي ما هي الا ما هي اعملها presentation. حاضر، هقعد اقفلها بقى بعد كده، زهقني. حلو. انا عملت هنا ايه؟ just a copy paste of the indications of the 3 types of diuretics. Now لو انا هطلع من درس الدايوريتكس بحاجه، this is going to be the most important slide. Your appreciation of the differences between the 3 types of diuretics in each indication, how important is each وايه الترتيبه. So in hypertension, so in thiazide diuretics, hypertension comes at the beginning. And why is this? Because they are moderate diuretics, and because their action in hypertension goes beyond their diuretic action, they are going to decrease the sodium content of the vascular wall just as they did مع مين؟ مع distal convoluted tubule. في الآخر الصوديوم كله هيقل. طب البلاد فيسل الصوديوم بتاعه قليل، is it going to be more or less responsive؟ It's going to be less responsive with less vasospasm, with vasodilatation. Okay, so they are useful even in subdiuretic doses. They are used alone with other antihypertensive drugs like ACE inhibitors, and they are also very important if you have a vasodilator for the treatment of hypertension. If there is severe hypertension and you need a vasodilator, what's the problem with all vasodilators? حاجتين. Sympathetic stimulation, immediate reflex tachycardia, delayed salt and water retention. So in hypertension، معلش ده كنت بنط من حته للتانيه، بس انا حباكم تفهموا المواضيع على بعضها وتربطتها. patient بتاع الهايبرتنشن ده انت عايز تحوط عليه، تجي له من هنا يجي لك من هنا. If you are going to use just a vasodilator, you are going to make sympathetic stimulation. بتاع tachycardia عشان يزود الكاردياك اوتبوت، ويعمل لك salt and water retention to ايه؟ to increase. تمام؟ طيب لو انت جيت اديته بس حاجه تقلل الهارد كاردياك ورك، طيب ما هو انت مش قادر تدي الدوز الفل، فكأن البيشنت بتاع الهايبرتنشن you usually use more than one drug because you want to تعمل عليه كماشة بتجيله من هنا ومن هنا. واشهر combination ده ان انت لو هتدي diuretic with a vasodilator you are going to overcome the compensation by salt and water retention. So both are going to reduce the blood pressure, okay, with each other, and they are going to antagonize each other's side effects. تمام؟ That's why thiazides are very important in hypertension. Okay, but remember, they cannot be used in glomerular filtration rate less than 30 ml per minute, and this is the mechanism of antihypertensive effect. Next comes heart failure. Loop diuretics are the diuretics of choice. شايف الترتيبة؟ ما هو هنا hypertension وهارت فيلير وإديمة، وهنا hypertension وهارت فيلير وإديمة، بس مترتبين ازاي؟ How they are arranged, prioritized down. Mechanism of beneficial effect in heart failure: diuresis, vasodilatation, decrease in preload and afterload. إديمة يشتغلوا برضه hepatic, cardiac, renal, premenstrual tension syndrome. I know one of my friends that used to tell me, I just take a tablet of thiazide. I just take a tablet of thiazide. تقريبا حاجة معروفة. Premenstrual tension, salt and water retention. They take a tablet of thiazide. It will relieve شوية the tension. اوكي مش مكتوبة في حتة بس الناس عارفاها تعملها. في بقى غير كده idiopathic hypercalciuria and renal calculi. I am sure that before this when you used to memorize كانت بتوصل لحد هنا وتزهق. صح؟ دلوقتي you see it ايه؟ logical. This is very logical. Yes, hypercalciuria because I'm going to decrease calcium excretion. Renal calculi, again, I'm going to decrease calcium excretion. Okay, useful in hypocalcemia and osteoporosis. ده 4 indications. دي نمرة واحدة فيها 4 indications. Hypercalciuria, renal stones, osteoporosis beneficial. مش main treatment. مش هتلاقوه في treatment of osteoporosis. But it's beneficial. وإيه كمان؟ والhypocalcemia. Nephrogenic diabetes insipidus, I will not explain this in detail. It's something paradoxical. In nephrogenic diabetes insipidus, what does it mean, nephrogenic diabetes insipidus? What's diabetes insipidus? It may be due to a decrease in ADH production. تمام؟ أو ADH is there and is not working on its receptor. تمام؟ ADH is there but it cannot work on its receptor. They say that thiazide diuretics, it's written in Kadzong. You can read it in Kadzong if you want the detail, but this has too much detail. Thiazide diuretics, they help the insertion of actual channels that are going to help the reabsorption of water. That's why they don't need something to work through. They work directly, okay, on the cells to insert channels for reabsorption of water. Okay, call them porins, I think. These are the loop diuretics. Powerful, prompt, useful, emergency, severe, resistant. Okay, orally and injection. Thiazides are oral drugs. Okay, only one thiazide, chlorothalidone. They say in the USA it's there in parenteral. I have never seen it, so treat thiazides as oral drugs. Potassium retaining diuretics are oral drugs. Only loop diuretics are widely available in oral and in parenteral administration. First item in loop diuretics is edema. This is the first item. Acute pulmonary edema, peripheral edema due to heart failure or renal impairment and ascites. What's acute pulmonary edema? What's acute pulmonary edema? Acute left ventricular failure because any or mitral stenosis, which is severe, anything in the left side of the heart is going to, okay, it's going to produce pulmonary congestion, and if it's very severe and acute, it's going to be acute pulmonary edema تساوي acute left sided heart failure. ده طبعا هنا هتاخدوا بعد كده اللوب diuretics ليها فوائد كتير قوي. Hypertension comes second here. Its response to thiazides are inadequate, but the short duration of action is a disadvantage. بس في ناس مرة اختلفنا على سؤال السنة اللي فاتت and they told me but loop diuretics are not used in, they are not good in hypertension. Who said? There are certain patients, especially mean. Which patient? Patient with ها مين اللي مش هينفع معاه thiazides؟ When thiazides are not suitable, when are they not suitable? Renal impairment. That sometimes in acute renal impairment, you give furosemide to let the kidney work. طيب. Acute renal failure increases the rate of urine flow and enhances potassium excretion in acute renal failure. لسه كنت بقول خد الكلمة من على لساني. اوكي؟ كدني وقفت شغلها بفروزمايد. ادي فلويد وادي فروزمايد. Give fluid then give furosemide. Replenish the vasculature. Prepare this patient. Make sure that the patient is not hypovolemic and give furosemide. Hypercalcemia, exact opposite. Okay, furosemide and electrolyte sodium and potassium replacement. ليه؟ I know there is going to be hyponatremia and hypokalemia, and I'm going to give furosemide to excrete the calcium, so I need to replenish these. Okay, طيب. What about the potassium retaining diuretics? This is a different story. Let us finish with the loop and come back to the potassium retaining diuretics. طيب. الايه ده؟ ها؟ ايوه طبعا. طيب اوكي. سو ثيرابيوتيك يوزز اوف thiazide diuretics خلاص احنا قلناهم. الادفيرس ايفكتس خلاص we know all of them. الهايبوكاليميا how to treat it تمام. These are options. الكونترا indications digitalis toxicity because of the hypokalemia. Corticosteroids. Why do corticosteroids cause hypokalemia? This is from physiology. Mineralocorticoid action, aldosterone-like action, advanced liver disease, the advanced kidney disease. Of course, this is a contraindication. Advanced liver disease, if it's advanced, yes, it's a problem. Diabetes is a relative contraindication because they will cause hyperglycemia, where they will cause hyperuricemia, where they might be phytotoxic. تمام. Loop diuretics, these are high ceiling diuretics. Okay, what does it mean high efficacy or high ceiling diuretic? What does it mean high efficacy? And what's more important, a drug's potency or a drug's efficacy? Why is efficacy more important? Who said? Who said efficacy is more important? I want to hear. Because it's right, efficacy is more important. Why? What's potency? Potency is simply, it translates into the dose you are going to give. يعني مثلا statins. You have simvastatin. I think the dose of simvastatin, it may be 40, 80. Atorvastatin, it will be 10, 20. Rosuvastatin, it will be 5. Which means that which is more potent? Rosuvastatin. Now, efficacy is the maximum, is the dose that gives you the maximum effect. How much you can increase the dose. For example, if this drug is very potent, but after the 5 milligram, it's going to be toxic. Can you increase it? You will not. This drug is not potent, but you can give 5, 10, 20, 40, 80, and it's still safe, and it will be efficacious. So which is better drug? High efficacy. So efficacy is a very important parameter for you as clinicians for your everyday work. Type. So they are high efficacy diuretics. برضو they need to be work from the luminal side and they need to be excreted. Now there is a very logical question. Do you know what's the question? يعني احنا we said the same thing with thiazide diuretics. They need to be excreted into the lumen, and that's why in renal failure they will not work. Why will loop diuretics work? First of all, they depend on prostaglandins, and I have a little explanation. It's not written in a book. It's my own logic or my own thinking. If you're talking about something which is moderate efficacy, and it's not going to be excreted much, and you wait for it until it reaches the distal convoluted tubule, if you have renal impairment and it's already moderate, it will not work. However, if you have renal impairment, and this much is excreted or secreted, this very little much is secreted, it will reach the thick ascending limb of loop of Hanel, and it will work. Okay, so it's targeting a very powerful mechanism. So even a very small bit of it is going to work. This is, of course, in addition that it might have other mechanisms like working on prostaglandins. Type calcium, magnesium. I showed you everything about the calcium. It is effective as a diuretic even with GFR less than 10 ml per minute. Okay, it increases the renal blood flow by prostaglandins, so maybe this is also an explanation. These are the uses, these are the side effects. Added to them, the hypersensitivity and the class allergy with sulfonamides and the ototoxicity. Again, contraindicated with conditions, corticosteroids digitalis, advanced liver here. We've not written advanced kidney disease. Same thing, relatively contraindicated in gout and diabetes. And these are some drug interactions. This is how I study drug interactions. If you have any list of drug interactions, try to think this way. Ask yourself, which are kinetic and which are dynamic interactions? Your drug, is it the one affecting other drugs, or is it affected by other drugs? Is the effect going to increase or decrease? This is the mind map, okay, by which you should think. Okay, for example, furosemide is going to affect displacing warfarin from plasma proteins, decreasing clearance of lithium. So furosemide here affects some drugs, okay, and furosemide, so this is going to increase or enhance. Furosemide is going to enhance the action of warfarin, it's going to enhance the action of lithium. It is going to enhance digitalis toxicity and increase ototoxicity and increase nephrotoxicity, but these, the ones above, are kinetic interactions and these are dynamic interactions. However, furosemide is going to be affected by probenecid. This is a kinetic interaction and is going to be antagonized by non-steroidal anti-inflammatory drugs. This is a dynamic interaction. So you can, to study interactions, you sometimes need to classify them like this. ليه؟ علشان digitalis is a competitive antagonist of potassium. You are not displacing digitalis from plasma protein binding sites. You are not affecting the metabolism of digitalis. You are affecting the mechanism of action of digitalis. You are decreasing a competitive antagonist of digitalis. So it is dynamic. تمام. طيب, let's go back to our book. تمام. Okay, these are what the potassium retaining diuretics. We have competitive antagonists of aldosterone اللي هو spironolactone, and we have direct drugs that directly act on sodium channels in the collecting tubules like trimethrin and amyloride. Okay, they are going to be sodium. Okay, this is the mechanism of action. The sodium reabsorption is going to decrease. Potassium secretion is going to decrease. So it's going to inhibit the sodium reabsorption, but it still is going to retain potassium. Sodium will be retained in the urine with its isoosmotic water, and the potassium will be retained, resulting in hyperkalemia. Hyperkalemia, of course, is very dangerous, especially this patient might be taking as well one of the antagonists of the renin-angiotensin system, such as ACE inhibitor or angiotensin receptor blocker, so, or beta blocker. Any combination of these puts the patient in the risk of hyperkalemia. Which is more dangerous, hyper or hypokalemia? Both are dangerous, but hyperkalemia can be considered more dangerous, so it's more difficult to correct. How are you going to correct it? I mean, with hypokalemia, both are causing arrhythmia. But with hypokalemia, you can give potassium. With hyperkalemia, وريني بقى هتتصرف ازاي. Okay? Then up to renal dialysis. Up to renal dialysis. Type, competitive antagonist of aldosterone, spironolactone, eplerenone, and finerenone. The other two drugs are important in heart failure. You will need to memorize them in heart failure. This is the mechanism of action. They are more effective in cases of hyperaldosteronism. I will review the indications now. Okay, and these are the direct inhibitors. Let's go back to this presentation to see how we compare the indications. Here are the indications. What comes in the very beginning? What comes in the very beginning? Hyperaldosteronism leading to edema, whether it's primary hyperaldosteronism or secondary hyperaldosteronism resulting from congestive heart failure, or resulting from hepatic cirrhosis, or resulting from nephrotic syndrome. So number one here is antagonism of aldosterone. بس خلي بالك in this hyperaldosteronemia may be primary because of an increase in aldosterone from a tumor or from secretion from the gland, but more commonly it will be secondary from anything resulting in chronic hypotension and hypoperfusion, like ascites, like cirrhosis, like heart failure, as you see. In heart failure, eplerenone, finerenone, they decrease the myocardial remodeling, again, because of the aldosterone receptors. They are important in cardiac remodeling. What's remodeling? What's remodeling? When you face the heart with a stress, the heart is going to, try to generate new myocardial fibers, but these are become fibrotic in time. And so these new myofibrils, they are abnormal. When they change to fibrous tissue, they call it cardiac remodeling. It's not effective and ultimately results in heart failure and decreases the survival of a heart failure patient. So we want to antagonize this remodeling. As I told you before, السم في الهارت failure هو compensatory mechanism. Again, so in heart failure, chronic kidney disease reduces the risk of sustained decline in glomerular filtration rate. This is something specific to finerenone. And again, in essential hypertension, as you can see, it's not متقدمة قوي في indication. These are weak diuretics. They usually they have to be added to other drugs. Or combination with thiazides and diuretics to synergize and correct for hypokalemia. And they say that spironolactone may be used in treatment of a condition where there is increased androgen, because it will antagonize androgen as well, work on androgen receptors. We go back to our book. So these are the indications. These are the adverse effects. Hyperkalemia. They are weak diuretics. Hyperchloremic metabolic acidosis. Spirono antagonizes digitalis because it will increase potassium, and only spironolactone will have endocrinal effects because it's a competitive antagonist of aldosterone. That's why it has the steroid nucleus, and it will have effect on some steroid hormone receptors. Trimethrin and amyloride are very important, very important. Why? These drugs are very old. They have been there, موجودين for market for a very long time, used in combination with thiazide or loop. يبقى لنا الثلاثة بقى الجروبس الصغيرين. Osmotic diuretic, mannitol في الانتراocular pressure increase والincrease في الانتراكرينيال pressure. دول أنا عايزة أعرف. Increase في intraocular pressure, increase في intracranial pressure, osmotic action. ده شغله. طب carbonic anhydrase inhibitor برضه هيتاخد في الجلوكوما يا اما systemically to decrease intraocular pressure acetazolamide or dorzolamide locally in open angle glaucoma. Sodium glucose co-transporter inhibitors دي example حي على حاجة اسمها drug repurposing. And example حي how analysis of data leads us to discover marvelous new treatments. What happened is they made a new group of drugs for diabetic patients who fail all therapies. As third line, احنا غلبنا في الهايبرجلايسيميا دي. So our last solution, let's throw the glucose in the urine. خلاص. We have no other option. hyperglycemia, 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 we are going to throw it in the urine. We are going to inhibit the sodium glucose co-transporter in the proximal convoluted tubule, so the glucose goes in the urine. There will be diuresis, and the glucose is going to drop. And diuresis is going to get us rid of some electrolytes, but not big enough so as to change the electrolyte level in the plasma. What happened is, those diabetic patients very commonly are cardiac patients. Very commonly, they are cardiac patients. They might suffer from chronic heart failure. So let's analyze the data. هات لي يا عم آلاف الداتا. ما هي دي this is the strength of data in developed countries. They record everything. And they have something called the claims data. Because when a patient gets treatment from insurance. And the insurance will not give patient treatment unless they have full data, because this is money. So they have the full data. So let's compare those patients who took dapagliflozin, empagliflozin, blah, 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 canagliflozin, those glucose co-transporter inhibitors, to patients who did not take them. And guess what? تخيلوا, statistically speaking, those patients, they survived more. So it became an official treatment of heart failure, whether or not the patient has diabetes. That's why you see them here in the diuretic section, and you will see them in the heart failure. Okay, so they inhibit the sodium glucose co-transporter in proximal tubule. They are going to increase urine sodium and potassium, but no effect on serum concentration. Okay, it's mainly glucose and water. Third line anti-diabetic in heart failure, urinary tract infection. In the heart failure, you're going to hear more about their effects. We leave it until then. دي المقارنة ما فيهاش أي حاجة زيادة. يلا كمان نقول كلمتين على الأنجينا. Guess what? I want you just to know ايه ده ما كنتش عايزه كده، انا ما كنتش عايزه كده، ما كنتش عايزه كده. ايه يا جماعه؟ تمام؟ انا عايزاك تعرف بس ان هنا في main treatments وفي ايه؟ adjuvant treatments. فهنا classification is very important, but this is going okay. let me mark it برضو ايه يعني استحراس. اعرفوا بس الايه classification. تمام، مهم قوي. طب بعد كده في ايه؟ organic nitrates. بصوا يا جماعه، I have colored the mechanism of action, but I will not ask you about this mechanism of action in the coming exam. Why? Because in the end of year, there will be a written question entitled mention or describe the mechanism of action. And you are going to memorize mechanisms of action of any drug with a detailed mechanism of action. So this is one of them. أجلناه. It's not cancelled, not for the coming exam. But what's for the coming exam? For the coming exam, you should be able to know what are the actual dynamics, what's their effect. They are vasodilators, okay? Through increase in cyclic GMP, increase in NO, they produce vasodilatation mainly in big vessels and mainly on the venous side. Because they are powerful venodilators, they are going to decrease the venous return, decrease the end diastolic volume, decrease the preload, decrease the work of the heart. مفاجأة أخرى. When you are talking, أنا قلت لكم في الهارت failure ولسه هنقول بعد كده, you expect an inotropic, بس actually the important treatment is working against the compensatory mechanisms. In angina, you think you want something that will increase the blood flow, coronary blood flow. No! To do that, you need to do revascularization. The ultimate treatment is stenting and revascularization. You cannot dilate atherosclerotic blood vessels. So what's in your hands? اللي في ايدك ايه؟ You decrease the work of the heart. مش في ميس ماتش ما بين الاكسجين consumption والنيد والبرودكشن. طب انا مش قادره ازود السبلاي. What do? I decrease the demand. تمام. So there is بس عايز اتاكد احنا still recording صح؟ ماشي. Okay, some arteriodilation. This goes with the epicardial. انت ملاحظ حاجة in pharmacological actions you mention the good and the bad. After that you split them. The good ones are indications and the bad ones are adverse effects, cautions, contraindication. So you have vasodilatation of perhaps the large epicardial coronaries. This is something a bit good because at least you are not dilating the small ones. If you dilate the small ones, you do something called coronary steal. Okay? And I think you know it. Okay, meningeal causing headache, cutaneous causing flushing, pulmonary, they may increase they may decrease the pulmonary pressure. On the heart, they decrease the cardiac work. Preload more is decreased more than the afterload is decreased, so they decrease the oxygen consumption. Venodilatation, again decreasing the preload, blah, 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 all what I've said before. ده معناه they are going to result in hypotension. Here, decreasing the systolic more than the diastolic. Why? Because they are decreasing the diastolic, they are going to decrease the systolic more because they decrease the venous return. And the stroke volume comes from the venous return. So here the stroke volume is going to decrease because the venous return is going to decrease. So they are going to decrease the systolic blood pressure. Okay? Diastolic blood pressure will depend on arterial vasodilatation. They are more venous than arterial. تمام؟ ولا لا مش مقتنعين؟ تمام؟ طيب. Okay, relax. The reflex stimulation of sympathetic system leading to to maintain the diastolic blood pressure and increase contractility, tachycardia. Okay. So this is the reflex tachycardia. They are also spasmolytic on any smooth muscle, bronchi, biliary tree, GIT, and they can produce reflex stimulation of the respiratory center. These are all actions. Spasmolytic actions. Based on these spasmolytic actions, you will find very strange indications of nitrates. You'll keep hearing about it. Okay. At your level as an undergraduate, I'm not very much interested in these. If you are going to work, let's say, in surgery or going to work, let's say, in GIT diseases, perhaps you will find sometime an indication for nitrates. So you understand where it came from. That they have smooth muscle relaxing property. But I don't need you to memorize each and every indication of these. Preparations of nitrates, they are either short-acting, mainly, used in acute attack, immediate prophylaxis. Now, these details are in your clinical. These details are in your clinical. I will not ask in your coming MCQ exam about the detailed differences between preparations because this has a clinical air to it. So it's for your clinical exam. Therapeutic uses, all types of angina. Again, why is it good in angina? We keep repeating and repeating and repeating. It's good for the angina of effort. It's good for variant, good for unstable. Again, unstable angina is for your practical or clinical. And myocardial infarction, they are important. They are administered by IV infusion. Details about myocardial infarction are going again to be in your clinical. Congestive heart failure. Again, anything about acute angina, unstable angina, acute heart failure. It's all going to be in your practical. It's all going to be in your practical. حلو كده؟ تمام. جميل. Adverse effects, headache, كله based على ال vasodilatation, postural hypotension. Why? Why is it postural here? It's not an alpha blocker to produce postural hypotension. Why is it postural? Because they are venodilators, they dilate the capacitance vessels, so all the blood is there in the capacitance vessels. That's why it's postural. طيب, ايه تاني؟ Hypotension, reflex stimulation of sympathetic nervous system, reflex tachycardia, can be blocked by beta blockers or verapamil. Coronary dependence after prolonged exposure, sudden stop leads to rebound. Do you have the list of drugs that cannot be stopped suddenly? You have number one? noradrenaline, okay, anything by infusion, okay, you win, and beta blockers, and clonidine, and nitrates, okay, yeah, nitroprusside. So this is a list of drugs that cannot be stopped suddenly. Tolerance due to consumption of SH groups. This is detailed. This is related to the mechanism of action. Again, this will be in your clinical. The details about this are going to be in your clinical. What are the contraindications? They are allergy can be a contraindication to anything related to the cardiovascular side effects like the heart rate, like the systolic blood pressure. If it's too low, you cannot give it. Heart rate if it's too rapid or too low. Concomitant use of phosphodiesterase inhibitors. Okay, and this is a very important interaction. دي جت في فيلم من الافلام. في فيلم برضو جت فيه الانتراكشن ده. في حد كده في الفيلم خد مفروض واحد من السلدنافيل او التدانافيل وراح على الاي سي يو because he had a cardiac condition. He was taking nitrates and he took sildenafil. Both are causing severe vasodilatation with tachycardia and hypotension and can result in angina or attack of myocardial infarction. Yes, I was asked this question before. انت سألتيني يا مريم صح؟ Because the patient is already very much hypotensive. And the tachycardia you're going to get is a reflex tachycardia. You are going to get hypotension first. So you cannot risk giving the patient more hypotension aiming for the reflex tachycardia. It's risky. The basic here is hypotension. And the tachycardia comes reflex to the hypotension. So if the patient already very bradycardic, likely the patient is hypotensive as well. You cannot give him something that will decrease the blood pressure even more. لا هم في الأول هيبقى في reflex tachycardia because of the hypotension. So this patient with severe bradycardia is already hypotensive patient. Likely is already hypotensive. So you give nitrates causing more and more hypotension. Type calcium channel blockers. Now, guess what? I want you to know the chemical names that you have dihydropyridines and non-dihydropyridines. This chemical group is important. Dihydropyridines and non-dihydropyridines. Okay, I want you to know the names nifedipine, amlodipine, nicardipine, nimodipine, because each one has its particular feature. Nifedipine is the prototype. ده الأساس. Short acting. Amlodipine is a little longer acting, and both are important in the treatment of hypertension. We have nimodipine, which is important for cerebral hemorrhage, and nicardipine is important for emergency hypertension. So the four names you need to memorize. I'm interested only for you to know that there is difference in bioavailability and difference in first pass effect. The mechanism of action. Here there's no details. I will not ask for the coming exam about the details again of the mechanism of action of these drugs. Okay, however, I can ask about the actions, okay, and the difference between verapamil and the dihydropyridines, that it is mainly a cardiac depressant, negative chronotropic, and inhibits the SA node. Okay, anything that will prolong, will result in bradycardia, will prolong the cardiac cycle. And whatever, when you prolong the cardiac cycle, you prolong what? Mainly diastole. So you prolong filling outside the heart from the coronaries and inside the heart. Okay? They antagonize tachycardia or antagonize tachycardia of nitrates. It has a negative inotropic effect, so it's going to decrease cardiac contractility. It's going to decrease the cardiac work by this way. Negative dromotropic is going to produce or decrease AV delay, AV conduction, contraindicated at the heart block, and you don't combine it with beta blockers or digitalis because both, they depress AV conduction. Decrease automaticity and less peripheral vasodilatation than nifedipine, but potent coronary vasodilator. If you want to compare between verapamil and beta blockers, what is the main difference in dynamics or in actions? This is one thing. لو انا بقول فيراباميل انا عماله اقول نفس الكلام بتاع البيتا بلوكرز. نيجاتيف انوتروبيك، نيجاتيف دروموتروبيك، negative chronotropic, delay AV conduction, decrease work of the heart. However, vasodilator. So this is a negative inotropic drug that is a vasodilator. It's a calcium channel blocker. تمام؟ Can be used for bronchoconstriction. Yes, thank you very much. Okay, because it's a bronchodilator. So it will not produce imbalance in the smooth muscle tone. So thank you very much. It can be used in a very good alternative in patients with bronchial asthma who cannot use beta blockers. Thank you. طيب ايه تاني؟ اما بقى النايفيدابين powerful vasodilator, potent arterial, decrease total peripheral resistance, decrease afterload, also decrease in the preload but weaker, leading to decrease in cardiac output and the oxygen consumption with coronary vasodilatation. But remember that first of all, it might, all the calcium channel blockers and something called dipyridamole, they will dilate the small coronaries. What's wrong with this? If you have ischemia from the big coronary, this area is already ischemic. So it already has ischemic metabolites. It has metabolites already. So distal to this obstruction, the small arterioles are already dilated. Already dilated. You need to dilate the big one if you can. By a stent, by whatever way, you need to dilate the big one. The small ones are already dilated. But the problem is, if you dilate the small ones, you are going to dilate the small ones in the non-ischemic area. This is going to do what? It's going to steal the blood from the ischemic area. And that's why we call it the coronary steal phenomenon. So these dihydropyridines are very weak myocardial depressants. Do not depress the SA node, the AV node, are not negative inotropics. They are not anti-arrhythmics. Therapeutic uses of all calcium channel blockers, prophylaxis of all types of angina. There is no contraindication like the beta blockers, so they can still treat variant angina and can be used in angina of effort and unstable angina. And again, a list of beneficial actions. Okay. I have not highlighted these sentences, although they look very important, but I think you already know very much detail. فخلاص كده كفاية. Cardiac arrhythmias, verapamil, okay, and diltiazem are effective in supraventricular tachycardia because they block the AV conduction. Okay, decrease the heart rate in atrial flutter and fibrillation. And in hypertrophic obstructive cardiomyopathy, here the myocardium is very much hypertrophied. So there is outflow obstruction. يعني من كتر ما الميوكارديوم hypertrophied القلب لا عارف يتمدد to distend and take the blood, nor can it pump the blood. It's going to obstruct its own way. You need to see an image. Look up the Google for images. Sometimes when you give calcium channel blockers, you're going to relax this muscle and it's going to be good for hypertrophic cardiomyopathy. Hypertension, of course, especially nifedipine. And dihydropyridines reduce the severity of Raynaud's disease. Total opposite to whom? Beta blockers, okay? Cerebral spasm, subarachnoid hemorrhage. Here we have nimodipine in subarachnoid hemorrhage. With migraine prophylaxis, we have also some calcium channel blockers. So these are the indications. Adverse effects. Headache from the vasodilatation. Verapamil and diltiazem, they are inhibitory on the heart. Nifedipine is stimulating, resulting reflex tachycardia. Both can lead to hypotension, either from vasodilatation or from vasodilatation and a negative effect on the heart. Verapamil is very well known for constipation, and nifedipine is very well known for ankle edema. You see this in any relative or neighbor who is using calcium channel blocker. They use nifedipine or amlodipine, they come to you with ankle edema. You tell them this is from the calcium channel blocker. It's not really a problem. Or constipation. Constipation is a very bad side effect, but there are ways to treat it. Drug interactions, many with verapamil. Okay, of course, these are dynamic interactions. Verapamil and beta blockers, nifedipine and nitrates, they result in severe tachycardia. These are the ones I'm interested in. Here, I have highlighted indapamide because indapamide is there in the market and it's very commonly used. So it is related to thiazide diuretics and it's used in hypertension. So indapamide is something that you need to remember this name. Now, beta blockers in the treatment of hypertension, you use beta blockers without intrinsic sympathomimetic activity. They're the non-selective, the selective, the ones with the vasodilatation. They do not produce coronary vasodilatation. خلاص we agreed on this. ايه desirable effects يا ترى؟ انتوا عارفين بقى الكلام ده إعادة. What are the desirable effects of beta blockers in we're talking here angina, صح؟ Useful in prophylaxis of angina, exertional, unstable, but not in Prince metal angina. They decrease the heart rate, okay? They increase diastolic coronary perfusion time because they increase the length of the diastole, because when you decrease the heart rate, you increase the length of the cardiac cycle, favoring the diastole. And they prevent the tachycardia induced by anxiety and exercise and by nitrates and nifedipine, and they decrease the contractility. Some of them are anti-arrhythmics. مسألة decrease anxiety and exercise tachycardia. This is sometimes not very good for young people. يعني young people with angina, they don't like beta blockers because they want to work, they want to exercise, and the beta blockers they take for angina will not permit them to increase their heart rate. So they will not be able to increase their exercise capacity. They cannot go here and there. They feel they are tired. So it's not a very good drug for or group of drugs for young people. اتفضل. هعمل له ايه؟ مش احنا قلنا اتفقنا ان treatment of angina اساسا decreasing cardiac work. This is how they work. They decrease the cardiac work. احنا قلنا ان الفازودايليتيشن دي هي كده it will not benefit the atherosclerosed coronaries. انت بتستفيد ايه من الفازودايليتيشن؟ Veno decreasing preload, arterial decreasing the afterload. So you are decreasing the cardiac work. Here they are going to decrease the cardiac work by effect on the heart muscle itself. And over time, they will decrease the blood pressure. So if this patient is hypertensive as well, he is going to have a decrease in blood pressure. اتفضل. Yes. Talking about cardiac remodeling. Beta blockers, AC inhibitors, angiotensin receptor blockers. These are the ones proven to increase survival and improve remodeling. طيب في undesirable effects of beta blockers. When you have long diastole, this is paradoxical. When you have a long diastole, the heart is going to fill more. It's going to increase the end diastolic volume. So there is actually more load on the heart to empty this. So it's paradoxical. But usually, we don't give them alone. We give beta blockers with nitrates. Nitrates are the main, so we give nitrates and beta blockers. Beta blockers and nifedipine, okay? So it's usually two drugs to cancel out their side effects. Okay, not as an add-on, of course, they need to be regular. Antiplatelet drugs, you just need to know that antiplatelet drugs are used in angina. So just the antiplatelet drugs are important. Now, for each one of these other anti-ischemic drugs, just know the mechanism of action. So nicorandil, this is nitrate-like nitrodilator. We just need the mechanism of action, okay? That there's something called nicorandil used as an anti-ischemic drug with its brief mechanism of action. Trimetazidine, that this is a metabolically acting drug because normally the ischemic myocardium will shift to free fatty acid oxidation, and this will increase the oxygen requirements and increasing the oxygen demands. Preventing this metabolic shift is going to improve the myocardium metabolically. الترايميتازيدين ده انا كنت عامله عليه رساله الدكتوراه بتاعتي. That was how many years ago? More than 20 years ago. And it's there. And it has never been a wow drug. It is just there. So it's an adjuvant drug. It's a metabolically acting drug. It's not a very important drug. However, it is there in the market. So you need to know that there is a drug called trimetazidine and that it has a metabolic mechanism of action, which is preventing the shift to the fatty acid oxidation. That's it. Okay? So it's a fatty acid oxidation pathway inhibitor. It's an add-on medication. It doesn't work by itself. Ranolazine decreases the calcium overload in the myocardium. It will decrease contractility. Again, it's not a main drug. Now, I wish I can explain arrhythmia in more detail. Honestly, we don't have time. So I advise two things. During the days of the COVID, I gave all the cardiovascular system. It's recorded and it has links. Arrhythmia was one of them. If you like, you can listen to it. With arrhythmia, I'm going to be very specific. I ask only for three things. You are going to know it, but I advise you to listen to the arrhythmia lecture, and perhaps من هنا لحد the end of year exam, I'm going to provide something decent about arrhythmia because it's not very orderly within your material. Okay? Type ivabradine, it's very important in angina. Why is that? What's the worst thing in angina to have for an anginal patient is to have what? Tachycardia. Tachycardia is the worst load you can have on the heart. Why? Because this is a shorter cardiac cycle. Shorter cardiac cycle, shortening what? Systole or diastole? Shortening the diastole. So shortening coronary filling. So if the patient is tachycardic and he has sinus tachycardia, this ivabradine is specifically to block the IF channels in the SA node, so it is good for sinus tachycardia. Okay? If the heart rate is more than 70 and you need to control the heart rate. You are going to see it again in heart failure. Combinations are important, yet they are easy. Because you can combine nitrates with beta blockers and you have the advantages. You can combine nifedipine or amlodipine with beta blockers and you have the advantages. This is a repetition telling you the action of each. And you can combine nitrates and nifedipine or amlodipine with a beta blocker. You can have the three. Beta blockers are going to help you limit the tachycardia by nitrates and nifedipine. Yeah. Yes. وبعدين مسألة تعادل أو ما تعادلش. It's a matter of patient response and it's a matter of doses and it's a matter of what you have on the ground. مش في بني آدمين أصلا هم tachycardic شكلهم كده وفي ناس عندهم other reasons for tachycardia. You can give them a beta blocker. It's not every patient. This is one of the options that's possible in some patients. تمام. Nitrates and verapamil or diltiazem, this is the least common because nitrate and verapamil ده تمام. verapamil و diltiazem and nitrates especially لو انا مش عايزه استعمل بيتا بلوكر. unfavorable طبعا verapamil بيتا بلوكر, nitrates and nifedipine من غير حاجه. too much bradycardia, too much tachycardia. Hypertension. We can يعني walk through hypertension as much as we can وما عندناش على فكره كتير لبكره على فكره. طيب مهمة قوي ترتيبة combination of drugs in hypertension. However, hypertension is a lesson which is more important in your practice. Drug choices, how to mix drugs in your practical. طب what's important in hypertension? Diuretics you already know. خالص ده احنا قتلناهم. We killed them. طيب mechanism of antihypertensive action of that. This is just a repetition. It's a repetition. Thiazides will loop. In place of everyone, a thiazide moderate, loop, severe, hypertensive emergency, hypertension with renal insufficiency, potassium retaining diuretic in combination with diuretics to counteract hypokalemia أو in cases with resistant hypertension where you want to add on another drug. طيب, what's the most important thing in hypertension? ACE inhibitors. They are very important because this is their place. ده بيتهم. هو كل دواء ليه بيت. ممكن يزور الناس في بيت تاني بس ده بيته. Okay? So this is their home. Okay? So this is a very important group of medication. These medications, and of course, يعني this is very important. I don't know if I have the other, you have the angiotensinogen, angiotensin 1, angiotensin 2. It doesn't have here the bit where it, look it in Google, where it tells you that the angiotensin converting enzyme, it's called, it has 3 names. It has, I think it's called dipeptidyl peptidase, and it's called kinase 2, because it will catalyze the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 is a vasoconstrictor. At the same exact time, it will catalyze the degradation of bradykinin. يعني لا هيرحم ولا هيخلي رحمة ربنا تنزل. هو هيصنع vasoconstrictor and it's going to degrade a vasodilator. Okay? It's not here on this diagram. You'll find it everywhere. It's very interesting to have this image in your head. This is the angiotensin converting enzyme. So when you are inhibiting the angiotensin converting enzyme, you are inhibiting the conversion of angiotensin 1 to angiotensin 2. You are inhibiting the production of angiotensin 2, and you are inhibiting the vasoconstriction, and you are inhibiting what? Aldosterone production. And you are increasing bradykinin. So, الانزيم بيهت في حتتين، والبلوكر او تقدر تقول الانزيم بيشتغل 3 حاجات لانه بيطلع الدوستيرون كمان. وانا هقفل ال3 حاجات دول. انا هقفل الفازو كونستريكشن بتاع الانجيوتنسين 2، وهزود الفازو دايلاتيشن بتاع البراديكاينين، وهقلل البرودكشن بتاع الالدوستيرون. Okay, so this is a very good inhibitor of renin-angiotensin system. طيب, so it will decrease the conversion of inactive angiotensin 1 to active angiotensin 2, decrease vasoconstriction produced by this angiotensin 2, decrease aldosterone, decrease salt and water retention, inhibit sympathetic activation because again this angiotensin 2 increases sympathetic activation. هو عمال يخرب الانجيوتنسين 2 ده طول ما هو ماشي. اوكي, it's يعني ايه frantic, decrease hypertrophy and remodeling of the heart، لان دي قصه مين؟ دي قصه الدوستيرون. تمام. decrease inactivation of bradykinin, so they are going to increase البراديكاينين حفظ صم. تمام. رغم انك قد تعرف ان تقول ان ده ميكانيزم اوف اكشن، بس يعني مهم قوي لانه الهايبرتنشن ما فيهاش الا ده تقريبا. لا فيها بصراحه، لا فيها. pharmacological actions mixed veno and vasodilator. يمكن برضو الميكانيزم اوف اكشن احنا اوريدي عارفينه، حتى ما بقول لكم احفظوه I'm not asking much، بس pharmacological actions are very important. They call them balance dilators because okay they produce arterial and venodilatation, but they more or less call them balance dilators. They decrease the afterload. They have weak venodilatation. They also decrease the preload شوية. Cardiac output is maintained. Cardiac output is maintained. نعم. بيعملش venodilatation قوي، وبيعمل vasodilatation on the arterial side، فده بيقلل الريزيستنس للفلو of blood، فcardiac output is maintained. This increase the renal blood flow, decrease glomerular filtration rate، لان هو بيعمل efferent vasodilatation، فما تعمل efferent vasodilatation هتقلل شويه الفلتريشن. So they decrease what's called glomerular hypertension. That's why they decrease proteinuria. That's why these drugs are drugs for proteinuria. اوكي، proteinuria حتى لو الدايابيتك patient مش hypertensive still they are good for proteinuria in a diabetic patient. diabetic proteinuria. طيب the pharmacological actions of ACE inhibitors are very important. Advantages: no decrease in the cardiac output. May increase actually cardiac output but in heart failure patients. البيشنت على heart failure وضعه مختلف. أما بتكلم على الكاردياك output in heart failure patient, I many times say that there is an increase in the cardiac output, although the same drug may not increase the cardiac output in a normal patient. You have, when you say increase for cardiac output, you need to recognize, are you talking about a normal patient or are you talking about a patient with decreased cardiac output? Exactly. Yes. Yes. decrease cardiac, so no decrease in cardiac output ممكن يزيد في الهارت فيلير. no postural hypotension عشان الفازودالاتيشن ما هياش sudden. no reflex tachycardia بما ان هو ما فيش severe sudden vasodilation. وكمان no abnormality in glucose or lipid or cholesterol. سيبك بقى من الثايزايدز والبيتا بلوكرز اللي عماله تعمل لك ايشي هايبر يوريسيميا وشي هايبر لايبيديميا وشي هايبر جلايسيميا والكلام ده كله. احنا بعيد عن الكلام ده كله، فما فيش كل الميتابوليك اكشنز دي. طب محتاجه اقول لكم يا جماعه ان الحافظه الصفحه دي صم. ها صم بقى الصفحه دي. ايه ثيرابيوتيك يوزز؟ احنا في درس الهايبرتنشن قلت لكم ده بيتهم this is their official house. They are antihypertensive drugs, especially in patients with high renin, in patients with diabetic nephropathy. They are going to reduce البروتينوريا علشان هيعملوا ايه؟ reduce glomerular hypertension او glomerular filtration pressure. And they are used of course in heart failure. Actually they are number one in heart failure. Heart failure decrease both the pre and the after load and they improve the cardiac performance وده هيزود من الكاردياك output في الفailing patient مش في النورمال patient. وكمان they will decrease the secondary hyperaldosteronism. بيشتغلوا على الcompensatory mechanism اللي هي أهم بالنسبة للبيشنت بتاع الهارت failure. Myocardial infarction, they will decrease the infarct size and remodeling of the heart. How to increase the infarct size? Can something increase or decrease the cardiac size? How can you decrease the infarct size? As I told you, this will be the result of a clinical trial where we have a group of patients randomized either to receive ACE inhibitor or no ACE inhibitor. We are going to see from the point of myocardial infarction. And for follow-up, those taking ACE inhibitor, the infarct will remain the same. Those not taking ACE inhibitor, the infarct will be worse. Why? Because there will be more strain on the heart, and this will put the heart at more strain and more compromise and increase the infarct size. حد فهم دي؟ هو مش هيشتغل على الانفاركت يصغره ويكبره. No. It's an effect that we know retrograde. طيب السايد effects dry irritant cough. Why? Because of increase in bradykinin. And for those patients who have this dry irritant cough, they can use angiotensin receptor blockers, which will block the receptors of angiotensin, hitting 2 birds, not 3 birds. This one hits 3 birds. ACE inhibitors, they hit 3 birds. Vasoconstriction, aldosterone secretion, vasodilatation by bradykinin. However, angiotensin receptor blockers, they hit 2 birds. Vasoconstriction, aldosterone secretion. So no increase in bradykinin and relatively less irritant cough. First dose hypotension, especially when the sodium is depleted from the patient. Okay, this is تقدروا تقولوا مثلا a hypovolemic effect because of the they are going to increase شوية they will antagonize the hyperaldosteronism. So relatively speaking, there will be more salt and water loss. So if the patient himself does not have enough fluid volume, they might experience first dose hypotension. So only in sodium depleted patient. hyperkalemia وانا مغمضه any antagonist of renin angiotensin system, bilateral renal artery stenosis, fatal renal failure. Why is this? ليه البيشنت اللي عنده bilateral renal artery stenosis will enter in renal failure if I'm going to give ACE inhibitors؟ اتفضل. بالظبط كده. اوكي، انت عبد الله ولا عبد الرحمن؟ عبد الله. تمام. هي الكدني شغاله بايه؟ الكدني شغاله بايه؟ kidney is working by the blood pressure. بس if you decrease the blood pressure this kidney is going to ايه؟ to shut down. شفتوا المحل اللي يبقى له بتاع كده وتروح مقفوله؟ تخيل الكدني دي لما انت تقلل لها البلاد فلو هتروح عامله ايه؟ shut down، مش شغالين. طيب when I have bilateral renal artery stenosis is the kidney hypo ولا hyperperfused؟ hypoperfused. طب how is the kidney going to protect itself? The kidney will increase the blood pressure to perform its own work whatever may be the conditions. تتحرق الدنيا كلها وتجيب لي blood pressure يشغلني. So it's going to increase the renin angiotensin system is going to be stimulated and produce hypertension to keep the kidney perfused and working. طيب what is the problem here? Let me tell you a little story. ولو دي مش للامتحان. You are a GP and you see this patient with hypertension and you know what is the percentage of primary hypertension? Is it much or low? 95%، أكتر من 95% primary. So you decide that this patient is a primary hypertension patient. First line, ACE inhibitor. Okay? What do you do to the patient? Comes with renal failure. Why? Because you have not excluded the 5 or less % chance of this patient having secondary hypertension. So how can you have the suspicion? Young patient, 30s, 20s, not 40 yet. طيب, it's strange to have this primary, to have hypertension to be primary. This is question mark number 1. You examine the patient, you put your stethoscope where? On the heart? No, where? On the abdomen, on the loin. And what do you hear? Bruit, strange sound. You have high index of suspicion. By having this high index of suspicion, you save this kidney. Okay? That's why this is very important. The importance here مش ان انا بالعنية بروح هدي البيشنت ACE inhibitor وهو عنده bilateral renal artery stenosis. المشكلة ان انا I don't know he has renal artery stenosis and I have to discover it in the first place. تمام؟ طيب contraindicated second or third trimester of pregnancy. Again, very interesting because usually what do we say about contraindication of drugs in pregnancy? Usually in the first trimester. طب imagine بقى in the first trimester they are category C. In the second trimester and the third trimester they are category D. Maybe D or X, I'm not sure. I don't memorize them. That's why, because this is the period where the kidney becomes organogenesis for the kidney and kidney function. So you cannot block the renin-angiotensin system in a pregnant patient in the second or the third trimester because you are messing up with the actual formation of the nephron. Okay? So here the contraindication in pregnancy comes in the second and the third, not the first. طيب what happens here؟ دي جات لي مره حد كان بيسالني سؤال USMLE. تمام؟ ايه سؤال USMLE؟ واحده pregnant بيعمل سونار لقى فيه oligohydramnios. What can be the drug that she's taking? And there are choices. وانت مغمض oligohydramnios means there is decrease in the fluid around the baby. Where does the fluid around the baby come from? from the baby's urine. So oligohydramnios, there might be a problem with the baby's kidney. So which drug can affect the baby's kidney? Many choices can ACE inhibitor, spot diagnosis, ACE inhibitor. عبد الله. عشان ده ما تصبر كده لحد ما يجي البراكتيكال واقول لكم هنعمل ايه، والاند اوف يير واقول لكم هنعمل ايه. اي حاجه انا بهتم بيها هنا ممكن تيجي في الاند اوف موديول. اي حاجه انا نطقت وقلت انها للبراكتيكال ان شاء الله للبراكتيكال ان شاء الله ما انساش ان شاء الله. تمام ان شاء الله. بصوا يا جماعه انا I want to tell you something. في حاجه احنا ما يعني دايما بننساها، وهي حاجه من الحاجات اللي في الدنيا حلوه قوي. It's good communication. تقريبا بنسبة أكتر من 90% anyone who sent me something on WhatsApp I have responded. After your exams, any query that I got after the exam, if I examined it وطلعت you are justified, I very simply either cancel the question or consider two answers or whatever. بس احنا اللي بيحصل ايه؟ ساعات بلاقي كل واحد غلط في سؤال عايز يجي السؤال ده غلط. تمام؟ بس really sometimes you are justified. For me no problem at all. خلاص؟ so don't worry. Please don't worry. Okay؟ طيب. اوكي بروتينوريا do frequent urine analysis. ممكن ساعات يعملوا بروتينوريا. نيوتروبينيا frequent blood count. في سايد افكتس كده، في سايد افكتس بقول لكم دي بشعه بشعه. من ضمنها ايه؟ النيوتروبينيا. ليه؟ صفحه في الكراسه، صفحه في التجميع. open a new page. drugs causing neutropenia or agranulocytosis. list to remember. Why? Because this patient will get any symptoms. ها؟ هيصحى الصبح كده يقول ايه ده في المرايه انا عندي نيوتروبينيا؟ No. Where are you going to see this patient? In the ER with life-threatening infection. على طول. طب another nasty side effect. ادويه اللي بتعمل السايد افكت دي غالبا they don't survive in the market. What do you think? Also in the blood. Thrombocytopenia. تمام؟ يبقى اللي تسمع عنه انه بيعمل نيوتروبينيا او ثرومبوسايتوبينيا you need to follow the patient blood picture. Taste dyschousia, alteration in taste, anything can use to allergic manifestation especially اللي ليهم SH containing group. ها ايه تاني؟ اي حاجه؟ الكورتيكوستيرويدز بتعمل ليمفوبينيا. they are more effect selective على الليمفوسايتس. تمام؟ ومين قال ان الكورتيكوستيرويدز are immune suppressants؟ they are immune suppressants. اوكي؟ طب ما هو طبعا هو البيشنت اللي on corticosteroids is an immune compromised patient. تمام؟ طيب بعد كده drug interactions. potassium depleting diuretics will result in severe hypotension. potassium retaining diuretics hyperkalemia. non-steroidals will antagonize the hypotensive effect. والانتاسيدز مش مهم قوي. مهم انكم تعرفوا ان في الكابتوبريل ده قديم، ده كده كده active drug. it's not affected by food. عليه في SH group. short acting. تمام؟ بيتاخد كذا مره في اليوم. frequent angioedema. الحاجات اللي ما فيهاش SH group less side effects ولونجر تي هاف. فيها drugs active زي اللايسينوبريل، وفي برو drugs زي الانالابريل، بريندوبريل، بنزوبريل، بينازابريل، سوري، راميبريل، كوينابريل. طيب انا I don't expect you to recite the names of these drugs. يعني ما تمسكش كده وتقعد كده، لا. بس when you hear a prill you know it's an ACE inhibitor. This is what I want you to know. خلاص؟ طيب angiotensin receptor blockers again very important. losartan, valsartan, candesartan, telmisartan, irbesartan. I don't expect you to memorize the sartans, بس as long whenever you hear a sartan you know it's a angiotensin receptor blocker. They are pure antagonists, يعني no intrinsic activity, not partial agonists, decrease vasoconstriction, release prostacyclin, lead to vasodilatation, decrease synthesis of aldosterone. They hit two birds اللي هم الvasoconstriction والaldosterone, inhibit sympathetic activation by blocking presynaptic angiotensin 1 receptors on adrenergic neurons. This is something added, and there are angiotensin 1 receptors on adrenergic neurons that will increase noradrenaline release, prevent hypertrophy and remodeling of the heart. This is very important. Vasodilatation of renal vessels and decreasing glomerular hypertension. They are very much similar to angiotensin converting enzyme inhibitors, except that they do not increase البراديكاينين. برضو خلي بالك من potassium retaining effect. يوريكوزوريك effect قليلة، ماشي. ameliorate hyperglycemia induced by diuretics، ماشي. الميتابوليك actions, these are not, I don't consider them very important. Okay. Therapeutic uses are similar to ACE inhibitors. زي ما انتم شايفين انا مش مهتمة خالص بالاسبايرين، بس you know that there are direct renin inhibitors existing in space. Sympathetic depressants, you have already taken them before. في centrally acting sympathetic depressants, I'm interested in the general mechanism of action that stimulation of the alpha-2 receptors in the brainstem is going to decrease sympathetic outflow, going to decrease renin secretion, going to decrease noradrenaline release. دي أدوية حلوة قوي للهايبرتنشن. طيب ايه ميزة الالفا 2 stimulants عن الالفا 1 بلوكرز لو قلنا ان الاثنين sympathetic depressants؟ انا بفكر في سايد افكت معينه، في سايد افكت معينه. there is a side effect which will differ. ها yes, tachycardia by alpha blockers, bradycardia by alpha 2 agonists. This highlights or opens a new page in your copybook in which you are going to classify anti-hypertensive drugs according to their effect on heart rate. Mention 3 antihypertensives causing tachycardia. Vasodilators, direct vasodilators. Alpha blockers. طيب ماشي، خليهم 2 وبعدين نشوف. طب mention 3 causing bradycardia. Beta blockers. ها verapamil. ها alpha 2 agonists. Alpha 2 agonists cause bradycardia. I will not ask you this directly, but it has to be arranged in your head. When you're approaching a hypertensive patient and giving him a drug, you need to mind the heart rate. You need to mind the heart rate. So you know which of your drugs is going to cause tachycardia and which ones are going to cause bradycardia, because this is important. So the beauty of the alpha 2 agonists or the central ones or the central CNS depressants is that they cause bradycardia. Something like alpha-methyl dopa, it passes the blood-brain barrier, transformed to alpha-methyl noradrenaline. I am only interested in the indications, hypertension with pregnancy. This is interesting. Perhaps you have it also in the practical. Why? Because there are certain limitations. When there's a pregnant patient, you cannot give her ACE inhibitors. So there are certain drugs that are favorable in the pregnant patient. Labetalol is good as well. Mild and moderate hypertension, especially because if you give a beta blocker because you're not treating the patient, you're treating 2. And you want to reduce the blood pressure, but you want to maintain the placental blood flow for the baby. Wallahi, I know one of my relatives, she's been hypertensive during her pregnancy with severe hypertension. Her baby is not abnormal, but he's not normal. He's not normal. You compromise the placental blood flow when you give drugs that decrease the blood pressure. So this is a very delicate point. Of course, you're going to take it in OB/GYN in details. mild and moderate hypertension, especially hypertension with renal insufficiency لان هم they increase the blood flow. مهم قوي ان في CNS side effects. You're going to decrease the sympathetic, derive even inside the CNS. You produce sedation, you produce depression, nightmares. Okay, parasympathetic predominance because you are inhibiting the sympathetic from the member, so you can have bradycardia, as I told you, and nasal stuffiness, and sometimes diarrhea. Other adverse effects, sometimes with methyl dopa, there is liver toxicity, bone marrow depression, and edema. So as you can see, I've highlighted, not all of the side effects. Clonidine has a central action as well, stimulates alpha-2 adrenergic receptors, decreases sympathetic outflow, noradrenaline releases decrease, used in hypertension, mild and moderate. Okay, prophylaxis in migraine headache, morphine withdrawal, because clonidine, it enhances analgesic actions. They put it with spinal analgesia even. يعني الناس اللي بتاخد spinal anesthesia, okay, sometimes they use clonidine, okay, to augment the analgesic action. Combined with morphine, encodal anesthesia provides better anesthesia. I was just talking about it, I know it from before, بس أنا ما كد لسه بتكلم. Drowsiness, dry mouth, stopped suddenly, rebound, hypertensive crisis. The drug should not be stopped suddenly and it causes bradycardia. What time is it now? Okay, what do we have for tomorrow? For tomorrow, we have only the vasodilators. We have the heart failure. And what else? Arrhythmia. Okay, heart failure, it is almost half of it because acute heart failure is going to be in the practical. Most of the digitalis is going to be in or end of year, only a very small part of digitalis. So it's almost half of the heart failure. And arrhythmia, I will tell you 3 things to memorize in arrhythmia. That's it. 3 things, that's it. So we're left with the blood and anemia. And they are very anticoagulants and anemia, and they are very important. These are for tomorrow. I will start, inshallah. Or do you want us to continue? What do you want? Do you want to continue a little bit? Tomorrow? Okay. But tomorrow we need to finish exactly at 4 because I have something at 4. Huh? You want? But not everyone knows. This is the problem. We'll start exactly, inshallah, at 2. Inshallah, and it's going to be good. Inshallah. Okay? Yeah, thank you. Thank you very much. Thank you.